Ladies and gentlemen, thank you for your patience in holding. We now have our presenters in conference. Please be aware that each of your lines is in a listen-only mode. Questions will be facilitated within the web presentation today. If you have a question, please submit your question at any time by using the chat pod located on the right of your webinar. You may also download a copy of today's presentation from the Files pod located above the chat pod. It is now my pleasure to introduce moderator Chris Hund. You may begin.
Thanks, Chantel. Hi, everybody. Hope you're doing well. Good afternoon. Welcome to the April 2016 TeamSTEPPS webinar, monthly webinar. In this webinar, we have Bill Laxton from HCA with us, and he'll be talking about improving clinical performance and safety culture through the TeamSTEPPS implementation that they were doing in their rather large system. Just a few rules for engagement. You could be listening to this webinar in two different ways. You can do it through your computer, or you can call in and do it through your phone if your computer doesn't have the ability to do that. So do it either way. If you do call in through your phone, please mute your computer speakers. Like Chantel said, we're going to do a Q&A session at the end of the presentation. As you think of questions, text them into that chat box you see on the right-hand side of your screen. We'll collect all the questions, and then I'll try to put together some sort of coherent discussion with Bill at the end. Don't leave all your questions to the end because when we get lots and lots of questions coming in the last 5 minutes, we may not get to you. So as you think of your question, type it into the chat box, and it'll probably be more likely to be answered that way. If you don't get your question answered, we will work with Bill to get it answered, and then we'll be able to post it on the TeamSTEPPS portal so everybody will get their questions answered regardless of when they get asked. All right, a couple of upcoming TeamSTEPPS events. We have monthly webinars that are scheduled through August of 2016. Right now, the May webinar is open for registration, so that's going to be a great one with folks from ChristianaCare. We have Master Trainer courses that are available through 2016 as well, so you can go on over and register for those. There's also the TeamSTEPPS Advanced course. And TeamSTEPPS Advanced is all about taking TeamSTEPPS tools and working to understand how these could be fully integrated throughout your system. So it's about spread, but it's also about how you could integrate them and connect them into other things that you're doing, other parts of your daily work. So it's about making TeamSTEPPS really the foundational element of your quality improvement journey. Great courses. Right now we have applications coming soon for 2 courses that are going to be this summer. One is going to be at Northwell Health, which is Long Island in New York, and the other one's going to be at the University of Washington in Seattle. We also have an online TeamSTEPPS course available if you're not able to go to one of the courses. This is for the normal Master Trainer courses, and the URL is up on the screen right there to register for an online course. To learn about any of these events or to register for anything, you can head over to teamsteppsportal.org. We have a helpline if you ever need us. There's the phone number right there. Also an email address, arcteamsteps@aha.org, and we'll get back to you as soon as we can. We can answer all kinds of questions for you about registration for courses or for webinars, but also if you have any questions about content, we'll do our best to answer it. If we can't answer your question, we'll find somebody who can. Okay, today's presenter is Bill Laxton, who's the Director of Patient Safety with the Hospital Corporation of America for the Clinical Services Group. Bill has been really instrumental in HCA's rollout with TeamSTEPPS. I've known him for good amount of years now, maybe 5 years ago I think we met, and they just do fantastic work, and we're really happy to have Bill here to present what's going on in HCA. So Bill, I will turn it over to you, and I'll see you on the other side for the Q&A.
Thank you, Chris, and thank you all for inviting me to present to you today. As you can see, our objectives, we want to tell you a little bit about our HCA story and what we've done with TeamSTEPPS, and I'll give you some little information about our organization as we start this process. We've learned some lessons, both good and bad, as I think you do with any undertaking. And what are some of the specific interventions that some of our facilities are using? And then what are some of the results we've achieved with that, and also where are we going in the future with TeamSTEPPS? A little bit about HCA. This organization was founded in 1958. It is a proprietary, publicly traded healthcare system. We consider ourselves one of the nation's leading providers of healthcare services. And right now we have about 168 hospitals, along with 125 freestanding surgery centers in 20 states and also in the United Kingdom. About 5% of all the U.S. hospital services happening in the country right now are performed at an HCA facility. As you can see, we have a large number of annual patient encounters, about 7.5 million emergency department visits, a little over 200,000 babies delivered each year. I think our chief medical officer tries to put that in perspective and reminds us that more babies are born in an HCA facility annually than are born in the entire country of Australia. So it's kind of puts it in perspective. Across the organization, we have about 225,000 employees. We have 37,000 active physicians. Now, of those active physicians, I want to remind you that not all are employed physicians by any stretch of the imagination. So let's talk about how we began the journey of trying to develop into going into TeamSTEPPS, and how did we start with trying to become a high reliability organization. About 10 years ago, we had 35 of our hospitals in 2 geographic locations, one in the Dallas-Fort Worth area, one geographic location, then also in the Nashville area, that engaged a vendor to help them focus on pre-surgery timeouts. They were really focusing on the checklist and going through the checklist and trying to compare the aviation safety model to that. After a couple of years of that, we soon recognized the need that we needed to really find a vehicle to move beyond just using a checklist, and that being hypercritical of the checklist. But what were the next steps we could take as we could start integrating those same fail-safe and try to prevent those failures and those mistakes from happening? And how do we get into other clinical areas besides just the surgery area? So the corporate risk staff, 5 of us at the time in 2009, attended a TeamSTEPPS Master Trainer program in Roanoke, Virginia, with the Carillion Health Systems. That they were a training center at the time. And we came back and started looking at some of the things. And those of you that have been through the Master Trainer program, when you come back, you kind of have the fire, and you're all hyped up. You've had a great pep talk, and you see all the applications that can happen with the tools that you're given in TeamSTEPPS. So we started in 2010 with on a voluntary basis with our hospitals. If they wanted to use TeamSTEPPS, we would help provide them some vehicles to get into a Master Trainer program and start looking at some implementation. So we had 19 hospitals at that time that wanted to volunteer to do the TeamSTEPPS program. Those 19 hospitals, as you can see from the slide, had a wide range of size. A major medical center with 760 beds down to a small community hospital with 67 beds. So a wide range of facilities, which is a good indicator of how versatile the tools you have with TeamSTEPPS can be, and what you can do with it. Then in 2011, we continued the process where we added an additional 11 hospitals. So our first 2 years of doing TeamSTEPPS, we had 30 hospitals, again, that ranged in size from a small community hospital, critical access, up to a larger facility. So we got about 8,000 beds using TeamSTEPPS in our system after the first 2 years. That voluntary participation has continued annually. So now we have over 100 hospitals in our system that are currently engaged in TeamSTEPPS. Currently in 2016, we've got a little over 100 hospitals that have been using TeamSTEPPS for greater than 1 year, so that they're beyond the implementation year phase on doing that. This year we have an additional 30 hospitals that are in their first year of implementation. And one of the things we do organizationally from corporate, without trying to be too prescriptive on our hospitals, and we require that they submit a written application that has the signature of senior leadership, which includes the CEO and the chair of the board. We ask at the end of this first year that they start defining their processes and clinical areas of focus. Make sure we have all the change team identified, that we have a physician champion. We require that a physician champion attend their master trainer program with them, so that we can start how do we work with our physicians and start building that team. Then looking at developing a cadre of master trainers. Last year, HCA founded or started their patient safety organization, and we do a lot of our, almost all of our clinical improvement activities now are done through our PSO. And what we've done starting last year is we started offering regional master trainer programs using our own cadre of master trainers geographically. I think we trained an additional 260 master trainers last year. We're on course this year for probably adding another 260 master trainers into our system as we start looking, how do we get that perpetuation and spread of TeamSTEPPS throughout our organization. We also, for those hospitals in their first year of implementation, require that they attend a monthly collaborative call. And we routinely now invite speakers from our hospitals who have been doing TeamSTEPPS for a number of years to provide insight to those that are in their first year of implementation. We ask to give a little information about the facility and the scope of services, what brought them into TeamSTEPPS, what tools they're using, what were some of the successes and barriers that they discovered. And so we start building that collaboration and start doing that shared learning, which is very important as we go through this. Those hospitals that have been participating in TeamSTEPPS for greater than a year, we do a quarterly call with the same format. We do a lot of collaborative sharing, lessons learned, what obstacles came up, what were some of the unexpected obstacles, and what were some of the unexpected successes that we had in SET. So we're very happy that our collaborative calls are seeming to really work for us as we move forward. We try to be results-oriented in our organization. We require the facilities that participate in TeamSTEPPS develop and monitor process and outcomes measures. And one of the things we've kind of softened on over the years is that I think sometimes the process measures get overlooked, and how important it is to get the process done correctly. We're having somebody monitor our handoffs, or monitor a timeout, or monitor some of the other things that we're doing from the process standpoint, so that we have the philosophy that perfect practice makes perfect, that if we do it correctly all the time and keep practicing in that way, it starts to become embedded in the way we do our day-to-day activities. And one of the things we've done this year is try to really align the outcomes measures with our clinical agenda from the clinical services group, where we start looking at things, and I'll give a little more detail about that later as we go through the presentation. But this is the first year that we've become more prescriptive in what those measures should be. And our clinical areas of focus are across the continuum of care. As you can see, all nursing units, ICUs, surgery, which includes one of our university affiliates is a pediatric surgery unit that they've done that in. We're looking at cardiovascular invasive procedures. So we're really pleased with the scope of areas of application for TeamSTEPPS as we looked at that, even Some of our behavioral health units have really made some great strides using some of the TeamSTEPPS strategies, and really happy with what's happened in some of our emergency departments. So what are some of the achievements we've included? We've had a sustained reduction in retained surgical items, retained foreign bodies in 8 facilities. A number of years ago, one of our busiest hospitals, an 800-bed facility in Las Vegas, has maintained no retained foreign bodies in surgery for about 5 years now, which is really amazing. They were recognized at AHRQ as a best practice for what they were doing with TeamSTEPPS, so we're really pleased with that. 71% of the units we have that are focusing on fall reduction have decreased their fall rates by an average of 40%. That's not to say that all of them have achieved a reduction in falls, but those hospitals still value what they're doing with the TeamSTEPPS tools that they use. So we have 18% of our units out of 11 facilities that have maintained a fall rate of less than 1 fall for 1,000 patient days, and we see more of that. We look at VTE and DVT prophylaxis use, setting up protocols and bundles. Those hospitals that have focused on that, especially with orthopedic postoperative units, have managed to achieve a 100% compliance of doing their DVT prophylaxis. And obviously, if we're doing the prophylaxis, we know that we're going to get results, good results with our patients, because the embolus are not going to be there, which obviously is a very bad outcome for that patient. One of our behavioral health freestanding facilities in the North Texas area also has an active behavioral health emergency department. And they were one of our early adopters. And one of the things they were concerned about was the concomitant medical problems that some of their behavioral health patients had after they were admitted, either voluntarily or involuntarily. And they weren't using the rapid response team the way that they felt like it was needed. And they were having a number of code events with the patients. So they managed to increase the use of their rapid response teams, or what they call a code green, that particular facility, and reduced the cardiopulmonary resuscitation rates to near zero in that particular facility. They've managed to sustain that high level of performance for over 5 years now using their TeamSTEPPS tools. And if they build their teams and start looking at even one of the measures is during a code that we appoint a leader to our team. So it's really some amazing things that we're seeing done. We're looking at handoffs from our emergency department to nursing units. One of the things that I'm not really taking sides on this, but a lot of times our emergency department staff, physicians, and nurses want to keep the hospitalists and the nurses from the units out of the ED, because they start wanting to try to treat the patient there instead of getting him up on the floor, so it ties up more of the resources in the emergency department. So we're seeing a good shift on that as we monitor. Is the right information being given? Are we doing it in a timely manner? Are we able to get our patients out of the emergency department and into a hospital bed and initiate that treatment? One of the important tools we're seeing used is shift handoff using bedside rounding. That's been very significant in our fall reduction activities. It's also been very significant in trying to include our patient into our healthcare team, and doing that. To give you an example of one of our facilities, and they've managed to do it on all their medical surgical units now, was having difficulty with getting patients put into bed and get their treatment plan activated and implemented. And pardon me. So they started what they called team admit using TeamSTEPPS tools. Then whenever a patient's admitted, they call team admit over the loudspeaker and whatever room number, and whoever is available is not occupied with a hands-on task reports to that room. Now, one of the side effects of that, pardon me, initially was that the patients became a little bit alarmed when so many people were showing up in the room, because they thought maybe they were a lot sicker than they thought they were. but it really helped to streamline the admission process for the patient as we do the assessment, initiate medication orders, get laboratory orders, and specimen handling. So bedside rounding has been a very important tool for us as we look at that. As a number of facilities that have used TeamSTEPPS have grown over the years, we've seen some other results that have come in on that as some of the other things. Looking at the sepsis and septic shock bundle use and mortality rates, we had several hospitals that started focusing on that last year. Our initial measurements after 1 year really looked promising, but I don't think we had enough time to really establish whether we're going to sustain those favorable results. But we saw a reduction in length of stay. We saw a reduction in mortality rate. We saw an increase in the getting the sepsis bundle implemented and get that first antibiotic in with a serious time frame. So I think that has real promise for us as we move forward with that one. We have noticed that we're starting to see some pain management reassessments and assessments on patients as they get their pain management going. Where that becomes important is as we go through the continuum of care is that it helps enhance the patient's experience in the hospital. Those of you that may or may not have been or had a loved one who's in the hospital, pain management becomes very important. And how do we make sure we're really assessing those patients and making sure we're reassessing that their pain has been alleviated from the medication. And then finally, one of the other things we've looked at is specimen handling. What happens when surgical specimens get lost, get mislabeled? You really can't make a diagnosis without really having done that. And you think also about specimen handling from just the nursing units to the laboratory with blood specimens and the culture specimens, those types of things. If you get a mislabeled specimen in the laboratory is going to say we can't perform any diagnostic testing on this specimen, so you have to go back and redraw the specimen from the patient. Again, those are those things that slow down your efficiencies as you're working throughout the day from the whole spectrum of care. And also you're having to restick patients and do those things. And again, we want to make sure that what we do is going to enhance that patient experience in our facilities. So where do we go from here? By the end of 2016, as I've said, we have 133 hospitals in our HCA family using TeamSTEPPS. We have not implemented any TeamSTEPPS programs in our ambulatory surgery centers. Our physician services group, we've actually attended the clinical care, clinical outpatient management TeamSTEPPS master trainer program in Chicago a year ago, and we're starting to look at how do we implement some of those TeamSTEPPS tools into our physician office practices as we go forward. One of the things we've done here in clinical services group, we have a clinical excellence team. Is that how do we, and part of that strategy on the clinical excellence team is how do we reduce clinical variance geographically? It should not be different to take care of a pneumonia patient in Florida as it should in Texas or California. So how do we start doing that? And how do we start developing those high-functioning teams? So one of the things we've started to do is to try to partner with the clinical excellence team on what tools can we use to help them enhance their implementation teams as they go out. Again, I mentioned that we have become much more prescriptive in what we are going to look at with our measures of success as we try to marry up our agenda with the clinical services group clinical agenda as we go forward. So our measures this year are sepsis, and that's sepsis, septic shock, and septic mortality rate. As we look at that, we are going to continue to look at falls with injury. That's obviously something that has to be looked at across all facilities. We want to make sure that we don't allow our patients to be harmed while they're in our care. Again, we're going to continue to look at VTE prophylaxis, and then also specimen handling. And although I haven't mentioned the labor and delivery in the perinatal area in women's and children's services, we look at oxytocin protocol compliance. How are we monitoring our patients with the use of oxytocin to augment labor as we go forward and do that? And also, how does that play into making sure we have healthy babies, so that when we have them in our nurseries and our neonatal intensive care units, that we have got them in a safe situation as we move forward with that. So what are some of the conclusions we've managed to draw from doing this? We at the HCA are convinced that we can improve clinical performance and patient safety in a multi-facility system. Geographically, we are primarily in Sunbelt states throughout the Southeast, and heavy presence in Florida and Texas, Louisiana, Kansas, Utah, and California, and the areas as we go forward, Nevada. So we know we can achieve results doing that. We've managed to develop some expertise in team training and HRO fundamentals. Our goal is really, in our push, is to how do we really get up to that next level to become a high reliability organization across the network. We managed to integrate teamwork and communication principles into healthcare, and to try to not to really flatten the hierarchy, but to make sure our teams are working together, and that our caregivers are talking to each other, and then they're talking the same language. That's always a big plus for us as we do that. I want to make sure we really optimize our patient outcomes. Again, that comes through communication and teamwork skills as we go forward. And then how do we reduce those adverse patient events that we do that? I always like to start a lot of my discussions with folks is to remind them that we can't help every patient that we treat, but we can harm any patient that we treat. So we want to make sure that we avoid those communication breakdowns. I want to make sure we eliminate that poor teamwork, and how do we get better at doing that? So, and Chris, I think that's puts me up against the questions and answers. We have plenty of time for doing that. I know I didn't cover all of our particular successes and barriers, and if someone would like to ask about any of the failures we've had, we can, I shouldn't say failures, less than optimal results would be the better way to phrase that. On some of the things we've done, I'll be happy to entertain those questions.
That's great. Thanks, Bill. Thanks for the presentation. It sounds like there is an incredibly broad amount of work that you guys are doing, and it's very impressive. So thank you for sharing that with us. We do have some time for questions, and we have a lot of good questions already in, so I think we'll definitely be able to keep it going here. So first things first, when you were talking about setting up your whole program in the beginning and getting these cadres of master trainers going, not only at the start within the hospitals, but then I think with your PSO, it seems as if you had a very good group of a diverse group of clinical types of people as master trainers. So how did you get physicians involved to be master trainers, especially since, as you said, not a good number of your physicians are not employed by HCA?
I guess it's been a difficult journey. Initially, it was much more difficult to get our physicians involved, but now because of, I think, the TeamSTEPPS success and spread across the country, we have a larger number of physicians who have heard of the TeamSTEPPS process. And I think a lot of our younger physicians are, their education is slightly different than it might have been for an older generation of physicians, as they are not left out on the pedestal to drive by themselves, and have been given a little more fundamentals about teamwork and sharing information. But all of our hospitals now have a full-time chief medical officer, and a lot of times that when we can get that collegial encouragement from a chief medical officer, physician to physician, that they can more readily identify a physician champion. And then one of the other things that we've seen is we've made a couple of concessions on instead of if our physician champion schedule is such that they can't attend with their team, we'll bring them into another training session and marry them up with another group so they can get the process down and then you go back and share with their team. So we try to be flexible with allowing their training and then getting them in there. Then when we get one physician gets in there and starts talking about it with their peers, it piques a lot more interest. So it's been a long process of doing that. So.
Thanks. Yeah, it sounds like it. That sounds like it's working. So we've got a lot of very specific questions, but I want to, before we get into the very specific questions, I'm going to hit a few of the big system-wide questions first to kind of narrow our focus. So a question is that we have for you is, do you think TeamSTEPPS can be effectively implemented in a unit if that particular unit is interacting on a regular basis with other units that aren't using TeamSTEPPS yet? So is that something you've run into in any of your hospitals, and what's your advice about it?
The answer is yes, it can be effective. And our experience has been is if we have a unit that's using TeamSTEPPS and they're using it effectively, leaders from the other units or staff from the other units, when they see that working and seeing that improved teamwork, will say, okay, when's it going to be our turn? We want to do this next. We want to try this and get that going. So it's almost like an infection that starts spreading through the hospital that people, they get excited about it and see when it's working. One of our large facilities in Kansas City started off doing that, and they had to actually say, okay, we have to prioritize who's going to be the next unit as it was rolling out. So.
Okay, so yeah, it's kind of that viral way of things going.
Yeah, I mean, especially if it's successful, those successes and wins that you see with effective implementation, it makes other departments really want to start getting into it and using it.
Do you ever have an opportunity, or not an opportunity, but more of a moment that you've heard of where a department may be really excited and raring to go because they're seeing how well it's working in another department, but it's just not right for that department yet because they're just not ready, maybe the culture's not there yet? So what do you do in those situations to kind of pull on the reins a little bit?
Yeah, we have seen that happen. One of the things, too, is that in our hospitals, they have a lot of local autonomy. And the local leadership is usually involved in making those decisions. Okay. And we have seen where we've actually seen some of our facilities, Chris, on year one on their implementation. We get halfway through the year starting down a path and then realize that this is probably not the best fit for what they were thinking about, and we'll regroup and go in a different direction with another unit. So that's where that local autonomy comes in, because those are the people at the sharp end of the stick and know better about what services they're providing, what their staff is like, and who's the most ready to undertake some change.
So this question that I'm going to ask might be answered by that local autonomy answer, but how have you seen TeamSTEPPS implementation be more effective? Is it where you're going to solve a specific problem and you're wanting to look at a specific problem and kind of use TeamSTEPPS as a quality improvement methodology? Or do you think it's been more effective through HCA as a full-on culture of teamwork and communication shift type movement?
That's a good question. I think a little bit of both.
I've seen it both ways.
Yeah, a little bit of both. I think that local autonomy on that unit as they start building that is good, because, like I said, the local leadership and the local people are they know better what's going on with their staff and more about their individual hospital culture as they do that. And then oftentimes we've seen some that they don't necessarily maintain the enthusiasm that we thought they would as initially it started. or they have personnel turnover and their master trainers are not there. So it just kind of like anything, it doesn't get the attention and the nourishment it needs. It tends to wither. And
right.
But we are seeing some cultural changes as we move forward. You know, healthcare is such a dynamic industry right now with so many changes that have gone on, and the technology that's available, and population growth, and so many other factors that let's get. It's kind of like drinking from a fire hose sometimes from our folks at the bedside. So we are
right.
seeing that culture shift slowly come around there as we see emphasis placed on patient safety and how do we get a better patient environment? How do we get our patients with a better interaction and an outcome with their care? So.
Thank you. Yeah. You talked earlier on in the presentation about both process measures and outcome measures that you're looking at. So somebody was asking a question about, how do we monitor at our hospital if each unit is utilizing the tools and making TeamSTEPPS part of their practice? So what do you do? What are some of the specific ways that, a handful of your hospitals maybe, because I'm sure they're all doing it a little differently, have done that, have seen if, the tools are actually being used?
One of the, I hate to call it, we've seen some people use secret shoppers.
Uh-huh.
They look through handoffs, and we do direct observation. They'll observe a number of bedside rounds per shift. Are they following if they're using SBAR, are they following the SBAR format? If we're looking at handoffs, that they will observe to see if their ticket to ride or their I-Pass the baton or their SBAR form is being completed properly. We know that they observe timeouts to see if it's being done according to the process that's been implemented. So we're seeing a lot of just observation as we do that, because again, I don't know if you've ever participated in that. If you see a team that doesn't routinely follow their script or follow the process that's been outlined, and then when they're being observed and then try to follow that script, they don't really do a very good job of it because they're not used to using it. So that's how we do the observations on that. And we look at it as compliance. Do they follow the script? Did they hit all the markers that they were supposed to hit? Did they involve the patients? I know some. But that observation too, how that's done. So.
Yeah. So I think we could shift a little bit into some more specific questions and some of the things that you guys are working on. You had just brought up, observing if people what they were using in handoff, be it I-Pass, the baton, or SBAR, or even something that's not a part of the TeamSTEPPS program technically, like the ticket to ride. But what are some of the methodologies that you guys have seen successful for handoffs that you've been using?
Well, just the ones I mentioned on that, and then a group of our hospitals on the East Coast, we're looking at handoffs between or handovers between the emergency physicians and the hospitalist, and how that was going. And one of their goals was to keep the hospitalist out of the ED, so they didn't tie up staff and resources trying to go ahead and start their admission process on the patient while they were in the emergency department bed. But what they would do is gather all the information and look at their written handoff process between the physicians, just a note tab, and then the medical director of emergency medicine and the medical director of the hospitalist would meet on a monthly basis to discuss any outliers that they had and what happened and why did it break down and how are they getting their successes. So it started building on that, where we actually had our physicians talking to each other, and we had our quality director and patient safety directors involved with kind of facilitating that process between the physicians, so it kept them on track and kept them on a timeline so they didn't get sidetracked on some other things. So that really seemed to be helpful with them, and it smoothed up that process so they could keep their ED throughput going and get their beds emptied out, not delay the patient's admission process. It worked on a lot of different levels on that particular process. The other is, as we see, Ticket to Ride is not necessarily from nursing unit to nursing unit on the handoff, but from nursing unit to ancillary services as we go to physical therapy or send our patients to imaging services and other places that, invasive procedures, GI lab, those types of places as that patient gets that, the caregiver that's assuming the care of that patient knows what all they need to be aware of on that patient, and the patient has a better idea that they don't have to worry about medications being skipped or, their IVs or other issues that go on that. So it's really helped up our game when we get patients into ancillary services.
That's great. A lot of people were really interested in what tools you were using to target the falls reduction, the program you were talking about that. So can you talk a little bit about the falls reduction program?
Yeah, we're really tickled with that because obviously I've been a nurse for close to 40 years now, and I know coming out of nursing school we were always talking about, wash your hands so you don't give your patients infections, and make sure you give them the right medication, turn them so they don't get pressure ulcers, and let's not let them fall as we do that. So, here we are all these years later, we're still talking pretty much about the same things as we go forward. But what we've done with that is that the bedside handoff has been critical on that, especially as we involve the patient. And part of that handoff process is to have that critical conversation with the patient that, especially if they're elderly, and you look at the CDC data surrounding elderly patients, if they fall, the catastrophic outcomes on those patients, the number of patients that are above a certain age that do fall annually. So we have that critical conversation with them that it is a matter of their safety, that they don't try to get out of the bed by themselves as we do that. And then we have some person that does an hourly round with that patient. It's time for you to go to the bathroom. We're here to do that, and I'll be back in an hour. So we're into the patient's room frequently to make sure that we give them the opportunities around toileting, because that seems to be one of the high-risk activities around the patient fall, is those toileting activities. So we make sure we're doing bedside rounding. We're doing hourly rounding with the patient, that our patients know who their caregiver is, and the caregiver knows about that patient's needs and activities that they can do. So that's where we've been successful at. And one of the things we really try to focus on is they measure their improvements, and we start looking at a rate. It's one thing to say, well, we had 10 falls this month, and 6 months later we're only having 1 fall a month. We want to know how many per patient day is, per 1,000 patient days. So we start looking at those rates, and that allows us to compare those 67-bed hospitals to those 850-bed hospitals on their fall rate. And then across what areas are we looking at fall rates? We know in senior care units or senior behavioral health units that our fall rate's higher. We know in our behavioral health units that we'll see a higher fall rate, the geriatric units. So we start looking at that. Then we start looking at our rehabilitation units, physical rehabilitation units. How does our fall rate look there as we're doing that? Are we supervising the patients properly? But we're starting to change our focus more on falls with injury. How do we prevent those patients from injuring themselves when they do fall? But those are the primary two we see with fall reduction, is the rounding and then the frequency of visiting the patient's room and offering them toileting activities.
Right, yeah. And so has there been any thought about encouraging the patients in those situations maybe to use certain tools, maybe something like a cuss or some way to speak up if they're having some sort of issue?
Chris, I don't know the answer to that and don't know if anybody's using it, but I'm going to start asking. I can tell you that right now. That will be the topic on our next collaborative call.
That's great.
Give me a second while I write that down. So.
Yeah. So another one of the projects you had talked about was working with your Sepsis Bundle. So what TeamSTEPPS tools are you using to support that Sepsis Bundle?
Again, that comes back to handoff.
Uh-huh.
And from ED and going into ICU, and then the rounding as we go through the patient's rounding. And again, when I say the handoff tool, so that we can get that first dose of antibiotics into that patient as soon as we can after their admission, and start intervening at an earlier time and recognizing the sepsis and earlier in the process, or recognizing the infection earlier in the process. Again, it comes back to the handoff, and I think our hospitals that are, the couple that are doing that right now are looking at using I Pass the Baton as their handoff tool.
Right, right.
Yeah.
Sounds good. How about in non-clinical environments? I know that you've talked about hospitals, and I know that you're, involved in looking at the, outpatient, ambulatory, office-based world because you guys were at that training. But what about in any of the non-clinical environments? Have you considered doing things there?
We have considered it. Actually, I can give you a good example of a non-clinical environment that we do. That our patient safety team here at the Clinical Services Group every Friday morning has a briefing.
Okay.
We call it 3 things on our briefing. What did I do this week, and what am I doing next week, and who's drowning, and who has some wavelength to help that drowning person out. So we and it's really been a good information exchange for us on a regular basis. So it seems to help us up our game and keep in better contact with what our team members are doing. Now, we've seen several of our hospitals that have what they have their Friday, their leadership briefing. All the department heads. On a very large teaching hospital, it might be more difficult, but they'll do a daily briefing or a daily huddle, and they try to limit it to 5 minutes. And here's what we're doing, and get it going. What's the bed availability? What's this? And it seems to work out pretty good for those hospitals, especially when you start looking at. I think it's important that as leadership starts implementing some of those tools, that it starts to permeate throughout the organization. If the CEOs saying let's huddle up and share this information, and the department manager goes back to the team leaders and they start doing their huddles and getting that information sharing going, it seems to just kind of perpetuate itself.
Right. That's power of sharing that example.
Yes.
That's for sure. I know that meeting efficiency is really helped by, sticking to a very specific time limit, and having a schedule, like specific questions you ask every time in your briefing. So that's great. All right. Well, got a couple more questions here. Keep you going if that's okay.
There it is.
all right. So you guys, I guess this is kind of a bigger question. We're getting towards the end here. So somebody was curious about a lot of the accomplishments that you're reporting. Do you feel that they're solely due to some of your TeamSTEPPS implementation work, or do you feel that they're working in tandem with other things that you're releasing at the time? And I know that's kind of very broad, and each different success you have probably has a different answer, but wonder if you could answer that in some manner.
I think I would be naive to think it was solely due to TeamSTEPPS. I think it marries up with some of the other clinical agendas that are being surpassed. I know sometimes I'll get the question from some of our field folks is, don't you people at corporate ever talk to each other? And we say, well, sometimes we do, and sometimes we don't. But I think it's a coupling of using the TeamSTEPPS tools and some of the other clinical agendas. I think what happens is if we have a particular clinical agenda, we want to make an improvement in this area globally across our organization. And those tools are available to help facilitate that improvement. That the TeamSTEPPS tools are readily available. I think it marries up very nicely with that. And I'll give you a very good example of how TeamSTEPPS really helped one of our organizations. Several years ago, there's a horrible event that happened in Aurora, Colorado. One of our affiliates in Aurora happened to sit across the interstate from that theater, and their emergency department was about half of it was closed down for renovation. And again, on a Friday night late, they had a busy emergency department going on, and they started receiving victims from that theater event in private automobiles with no pre-hospital care. They were coming in, and again, like I said, in private automobiles and in police cars, and I think they ended up with about 18 victims from that event in their emergency department during the night. But they had been using TeamSTEPPS where they routinely would start each shift with a brief, and then they would have routinely hold periodic huddles to determine what the status of the emergency department was, what was their wait time, how many patients did they have waiting to get into the ED, how many beds did they have available. So they routinely were using huddles and garnering the resources they needed through that use of huddles. And when that event happened, that was one of the first things they did was call a huddle, start gathering resources from outside the hospital with leadership, obviously enact your disaster plan. And they were very successful, and actually they had no patients no patient demise during the night. All the patients that presented lived. They had their emergency department pretty much settled down again by 8 a.m. the next morning. 100% of the staff returned to work. It took up to a year, but they did do that, and they credit the use of TeamSTEPPS and routinely doing that as part of their daily work is allowing them to handle that disaster. So that's a perfect one of the best examples I can think of for TeamSTEPPS.
Yeah, that's quite an amazing story. I know that was something that was presented at the national conference maybe 3 years ago now, and
yes,
quite
sir,
powerful.
It was. Yeah,
it really was. So last question for you. You've been quite kind going through all these questions, and we'll still have a couple more to send your way afterwards. But the last question I have is, so you have obviously so much going on. I think you said, you've reached 100 hospitals, and you're reaching out to all these different, ambulatory facilities perhaps, and it's just so many things happening. How do you capture what's going on in these facilities, and how do you transfer the learning and the knowledge from one to the next? I know that they're very kind of local, and that locality is important, but you definitely want to be sharing some of these best practices with each other. So what do you do for that?
Our organization is big on measurement. We measure a lot of different things. We are fortunate here at the corporate. We have a clinical analytics team with some statistician on the team that allow us to really evaluate the improvements we're making or the lack of improvement or how we're measuring that. So we do that. One of the things that we always strive to do better at, and I think we're getting better at it, is to do that shared learning. And we're doing that through our collaborative calls. And by involving those people at the facility level who are already implementing and the TeamSTEPPS tools and improvement processes, by asking them to speak at our collaborative calls to share their learning, share some of the obstacles they've had to overcome, to share sometimes it's 2 steps forward, 1 step back, and how do they overcome that. And I think that has generated a lot more shared learning for us over the last couple of years as we move forward with that. The other thing too is that our organization is, we have a division leadership, which usually in a geographical area we'll have a number of hospitals that are clustered pretty close geographically, and they have regular meetings with their team at that local level too, that helps them do some of the shared level learning at that level.
That's great. Well, thank you, Bill. Thank you for all of this. I speak for everybody probably that, very impressed by all the great work you're doing, and very impressed by everything going on in your system. So thank you for being here today, and we really appreciate it. And thank you all for joining us today. Yeah, and thanks to everybody who sat in and listened today, and there'll be a recording made available that will be posted on the website in the near future.
Chris, thanks for asking me. I really enjoyed talking about TeamSTEPPS, as you can tell. So.
Definitely. Thanks, Bill.
Thank you very much. Ladies and gentlemen, at this time, this conference is now concluded. You may disconnect your phone lines and have a great rest of the week. Thank you.